Good morning, student. From today's onwards, we'll discuss about the lecture on neurology. So, in neurology, the first lecture will be on cerebrovascular accident. I am Dr. Bhupendra Shah, Assistant Professor of Internal Medicine, B.P.Koirala Institute of Health Sciences, Dharan, Nepal. So, in today's lecture, we'll define what is stroke or cerebrovascular accident. We'll also discuss about the different spectrum of the stroke, how we can identify and classify stroke in emergency. We'll also discuss about the risk factors of the stroke. We'll also discuss about the clinical feature of the stroke involving different anatomical regions, and we'll also discuss about the management of the stroke. So what is stroke? So stroke, by definition, it is a condition where there is the focal neurological deficit due to focal vascular lesion, and that lasts for more than 24 hours. So it is the condition where there is a neurological deficit due to focal vascular lesion. So in another way, we can define the stroke as the pathological or imaging evidence of brain, retina, or spinal cord infarction. That's also a stroke. So how big is this problem, stroke? The worldwide data show it is the second only to the ischemic heart disease as a cause for the mortality, and for the adult disability, it is the number one cause for the adult disability. So it's a very, very big problem. So what are the risk factors of the stroke? So this is the data which I had taken from our research, that the principal author being me. Here you can see that stroke is more common in the male gender. Yes. Regarding the age, like the prevalence of the stroke increases with the age, and it's like around it's more common in smoker and person who takes the alcohol, and around 57.6% person are hypertensive, 25% are diabetes mellitus. So these are the risk factors for these strokes. So overall risk factors for these strokes, regarding the non-modifiable risk factors for these strokes are age is the important non-modifiable risk factors. Advancing age is the important risk factor for the stroke. Male gender is the important risk factors for the stroke. Family history of the stroke is the important risk factors for the stroke. Postmenopausal status for the female is the important risk factor for the stroke. There are some modifiable risk factors like smoking. Smoking, definitely, if you smoke, then you will have more chance to have a stroke. Alcohol consumption, hypertension, diabetes mellitus, dyslipidemia, cardiac disease. There are cardiac disease like valvular heart disease or atrial fibrillations, and these are the common risk factors for the strokes. But strokes can occur even in young. This is one of the case reported by our junior resident at the time, Dr. Abhishek Vandari. I don't think this is reported by this is reported by me, I think. Okay, this is Takayasu arteritis. So sometimes stroke is also common in different vasculitis, like Takayasu is a large vessel vasculitis, and stroke can occur in case of large vasculitis. This is reported by Dr. Abhishek Vandari, where he reported that cardiac disease like hypertrophic cardiomyopathy can cause stroke. And so definitely, so when someone asks you regarding the risk factor for stroke, you can say, sir, advancing age, male gender, a family history, then alcohol, smoking, diabetes, hypertension, and different cardiac disease. but the stroke can occur even in the young, especially if like stroke occurring in a person whose age is less than 45 is like stroke in young. And in this age group, the common cause of stroke are valvular heart disease, classically mitral stenosis, atrial fibrillations, different vasculitis, different autoimmune conditions like SLE, hypercoagulation, coagulable disorder like protein C or protein S deficiency, antiphospholipid syndromes. So these are the common cause of stroke in young. Okay, these are the common cause of stroke in young. So what are the spectrum of the stroke? So as a 9th semester student, the common spectrum of the stroke is like, one is ischemic stroke. In first picture you can see that, okay, in the first picture you can see that this is the ischemic stroke. This is the ischemic stroke where there is a blockage of the artery, and you can clearly see there is a blockage of the artery. And in the second picture, this is the hemorrhagic stroke. So stroke is of two types. One is ischemic stroke and the hemorrhagic stroke. And out of these two types, the ischemic stroke is more common. Near about 80% of the stroke is ischemic stroke, and 20% of the stroke is hemorrhagic stroke. So ischemic stroke is more common, okay, in our day-to-day clinical practice system. So with this background information, so if someone comes to the emergency or OPD, then how can you, if we suspect that that the person can have a stroke? For that, the one scale is derived, and then the name of this stroke is B-FAST, and you all have to remember about the B-FAST scoring system, where B stands for balance, E for eyes problem, F for face, A for arm, S for speech, and the T for time. B means if someone developed the acute impairment in the balance, like if you are all right, then if you like became unbalanced, then it may be the stroke. Classically, cerebellar stroke present with that history. Similarly, if someone has the eye problem, like sudden loss of vision or eye deviations, then that can be a manifestation of the stroke. Like facial deviation, then the arm weakness. If someone develops suddenly the arm weakness, then that may give us clue to the stroke. And someone develops suddenly the speech problem, then it can be a stroke. So basically, when we see the case, then you just give the 1 point to the each score, and then it can detect the stroke up to 95%. So always do be fast scoring. Okay. Then after identifying whether our patient has a stroke or not by doing the B-FAST scoring, the second is we need to identify whether it is the hemorrhagic stroke or the ischemic stroke. For that, the one scoring system is derived, that is Siraj score. You know, the Siraj is the name of the hospital in Thailand. They have derived that with this formula, there's 2.5 into loss of consciousness plus 2 into vomiting plus 2 multiplied by headache plus 0.5 multiplied by diastolic blood pressure minus 3 into atheroma marker minus 12. So if the score is less than -1, then it suggests the ischemic stroke. If it is more than 1, it's a hemorrhagic stroke. So mean that if someone has the loss of consciousness, then you can give 1. If someone is vomiting, then you can give 1, like that. Okay. So if someone has if someone has the loss of consciousness, vomiting, and headache, then the score will be definitely more than 1. Okay. So it favors the diagnosis of hemorrhagic stroke. So if someone say I have hemiparesis, along with that I have vomiting and headache, then definitely I will think of the hemorrhagic stroke. So presence of the loss of consciousness and vomiting and headache usually like give us clue towards the hemorrhagic stroke, and absence of these symptoms and presence of atheroma marker like diabetes, carotid artery sclerosis like favors the diagnosis of the ischemic stroke. So this is how we can interpret this scoring system. Then after knowing whether it is ischemic and hemorrhagic stroke, we need to identify where is the lesion. Where is the lesion? Whether it is in the cortex, at the level of the cortex, or in the coronary data, or in the internal capsule, or at the level of brainstem. We need to identify that thing. So if someone has the stroke at the level of the cortex, here at the level of cortex, so here, let's suppose someone has a stroke over here, the medial part of the frontal lobe, then what will happen? You will have the patient may have the weakness only in the lower limb, but not in the upper limb. So the pattern of the weakness will be the disproportionate one. There is like your upper limb will be more weaker than the lower limb, or lower limb will be more weaker than the lower upper limb, depending upon the location of the stroke. Okay, one. Second is there is some cortical signs like seizure. If someone has seizure, then that suggests the cortical stroke. If someone has the aphasia, then that suggests the cortical stroke. So, along with the hemiparesis, if someone has the cortical signs like speech problem, seizure, sometimes loss of consciousness, that usually suggests that the patient may have involvement of the cortex. Okay, cortex. Regarding the internal capsule, is the very like is the band of the fibers, like even a small stroke. Okay, in the small stroke, it can cause the dense hemiplegia. Mean that our patient may have the weakness in the face as well as upper limb as well as the lower limb if they have the dense hemiplegia at the level of the internal capsule. Okay, if someone has a stroke at the level of brainstem, then that patient may have if there is a stroke, then weakness, the cranial nerve will go of this side and there will be hemiparesis in opposite side. Okay, then that's called the cross hemiplegia. So if there is a cross hemiplegia, then that usually suggests the brainstem stroke. Along with that, in the brainstem, there are three parts. One is midbrain, pons, and the medulla oblongata. We know that from the midbrain, the third and fourth cranial nerve arises. So if there's involvement of the third and fourth cranial nerve, then we have to suspect the midbrain stroke. If there is involvement of the 5, 6, 7, and 8, we have to suspect the pontine stroke. And if there is involvement of the 9, 10, 11, and 12, then we have to suspect the medulla oblongata stroke. So that's how we can delineate the lesion of the patient who presented with us with the symptoms of the stroke. So till now, what we have discussed. So we have discussed the definition of the stroke, one, then risk factors, then how we can screen the stroke. Like for that, we need to do the B-FAST scoring. One, balance, eye problem, face problem, arm weakness, slurring of speech. Then we have to classify the stroke into hemorrhagic and ischemic stroke by CRAS scoring system. Presence of loss of consciousness, vomiting, and headache favors the diagnosis of hemorrhagic stroke. Then we have to look at the lesion, look at the anatomical site involved by analyzing the history. Okay. So what are the symptoms of the stroke? So most of the time we diagnose the stroke once the patient have motor weakness like hemiparesis. Classically, they have hemiparesis, but some stroke can present with only monoparesis. Some stroke can present only with paraparesis, but the common presentation is the hemiparesis, that one-sided weakness. Second, the patient can have headache. It's more common in hemorrhagic stroke, but it can be also present in ischemic stroke if they have the large stroke or large stroke. Then they can have headache because of the raised ICT. Patient with stroke can present with seizure if there is a cortical stroke, and they can also present altered sensorium if there is a large stroke or bilateral stroke, bilateral cortical involvement or brainstem involvement. They can present with altered sensorium. The signs of the strokes are like when you see the patient in the emergency, definitely we'll get the feature of the motor weakness. Like when you try to calculate the power, when you see the power, then there will decrease in the power. The reflex will be initially hypoactive reflex will be there. There will be the facial deviations. These are the motor weakness that we usually see. If there is a large stroke, then we can definitely get the feature of raised intracranial hypertension, like you can see the lateral rectus palsy or papilledema sometimes. And the plantar reflex may be upgoing in the initial stage of the stroke. But with the days, with the days passes, the in the initial days, the limbs are hypotonic because of the neuronal shock state. But after 1 week to 3 weeks, the limbs become spastic, reflex will be exaggerated. These are the features we will get in the later stage of the stroke. Okay. So what are the stroke mimickers? Like if someone presented to us with the hemiparesis, then what are the disease other than the stroke? It may be the brain tumor. Sometimes brain tumor can present with hemiparesis, especially brain tumor with hemorrhagic with hemorrhagic transformation can present with the stroke. Subdural hematoma, especially like who had a history of trauma or who are elderly people, they can have hemiparesis, and maybe just because of the subdural hematoma, we should be cautious regarding that. So it may be the like hemiparesis may be the just a presentation of multiple sclerosis. In that scenario, the usually patient give the history of the give the history of the relapsing and remitting pattern of the weakness. Similarly, sometimes metabolic encephalopathy, though it's like rare, it can present with hemiparesis. So these are the stroke mimickers, like we see often in the day-to-day clinical practice. So all the hemiparesis is not a stroke. Okay, yeah, that what we have to understand. What are the investigations we are supposed to plan? First of all, when you see with the patient in the emergency, like after doing the baseline test like CBC or random blood sugar and urea and creatinine, because sometimes hypo and hyperglycemia cause the neurological deficit. That's why we need to do the baseline investigation. The most important investigation that we are supposed to do in the emergency is CT imaging. CT imaging. CT imaging is not for to diagnose the stroke, but sometimes it helps us to identify the hemorrhagic stroke. Okay, if you do the CT early, then it may be the normal, because to see the evidence of ischemic stroke, at least we require 6 to 7 hours. But if you do the CT within 2 hours or 3 hours, it may be the normal. But even at that time, we can identify the hemorrhagic stroke. So CT image we usually do to rule out or rule in the hemorrhagic stroke. Definitely, we can do chest X-ray basically to see the complication. One of the important complications of stroke, that's aspiration pneumonia, or we can also get idea regarding the cardiac abnormality by looking at the X-ray. ECG for different rhythm abnormalities like atrial fibrillation, we can identify. Echocardiography for different structural cardiac lesion, we can do echocardiography and we can diagnose different structural cardiac abnormality. And definitely we have to do carotid and vertebral artery Doppler to detect or to diagnose the carotid or vertebral artery sclerosis. So these are some of the important tests that we usually do. Other than test, if someone is young, then definitely we will work up for the autoimmune conditions. Yes, autoimmune conditions we will work up for these conditions as well. Yeah. So CT head in stroke, this NCCT is enough, and you can see this is the hyperdensity, this is the big stroke. I think the involvement of the stream of the middle cerebral artery, there's a big this ischemic stroke, and which is seen as the hyperdensity. And in this in this side you can see the hyperdensity, and this is the hemorrhagic stroke. So this is hemorrhagic stroke. So we see this type of stroke in a patient with ischemic stroke, we see this type of stroke, and in case of hemorrhagic stroke, we see this type of CT. Okay. So how we are supposed to treat the patient? The treatment of the plan is supportive treatment. We have to always manage the airway. If there's a big stroke, sometimes patient will have difficulty in breathing as well. So we have to manage the airway. We have to give oxygen if saturation is not maintained. If there is difficulty in managing the airway, then sometimes we need to intubate the patient. We need to intubate the patient, especially if the GCS score is less than 8. We usually prefer the patient to put in the head tilt position, okay, head tilt position, because that helps us in preventing the aspiration pneumonia. Definitely, we need to control the fever, because as the hypothermia is a neurotoxic, and it can harm our brain. We need to control the fever. For that, we need to give the paracetamol round the clock if there is elevated temperature, and we need to control the sugar. And usually, we keep the sugar in between 140 to 180 if we are managing a patient with ischemic stroke. Okay, so definitive treatments are like thrombolysis is the definitive treatment. So if the patient come in the proper time, within the proper time, then we can do the thrombolysis and the thrombectomy. Definitely, side by side, we have to manage the hypertension. We have to give the antiplatelet for the secondary prevention. We have to give statin for the secondary prevention and physiotherapy to prevent the disability. Okay, to prevent the disability. So the thrombolysis is that thrombolysis is the hot topic in the stroke because time is neuron. Okay, and 2 million neuron is going to die if you delay the thrombolysis by each minute. So 1 minute delay in thrombolysis or 1 minute delay in regaining the perfusion can kill the 2 million neurons. So we have to bring the patient as soon as possible. Okay. So indication of thrombolysis is that if there is a clinical diagnosis of ischemic stroke, one ischemic stroke should be there. It is not done for the hemorrhagic stroke. And if the patient presented within 4.5 hours, so it's better if you come early. And the if CT imaging show no hemorrhage or edema more than 1/3 of MCA territory, like okay, and if the age of the patient is more than 18 years, and we should always take the consent before in like initiating the thrombolysis. So the time is neuron, and the common agent we use for the thrombolysis alteplase. Alteplase is the thrombolysis, and the dose for the alteplase is 0.9 mg per kg, where we give 10% bolus dose and remaining 90% in the infusion dose. We are also using the alteplase over here at the B.P.Koirala, and other like thrombolytic we can use the tenecteplase. Okay, we can use the tenecteplase. And other options by which we can restore the perfusion is thrombectomy. Thrombectomy, you can do the mechanical thrombectomy, and that can be done even up to 16 to 24 hours of the stroke onset. But for that, we need the further investigation with the MRI, and we have to show the mismatching between the perfusion. Okay, mismatching in the perfusion. Thrombectomy, we are not doing thrombectomy here, but people are doing at Kathmandu. Okay. The supportive care, as I have already told you, we need to supply the oxygen to maintain the saturation more than 94%. We can give antipyretics, and we have to maintain the blood sugar level in between 140 to 180. Then regarding the antiplatelet, we usually give the aspirin or clopidogrel, only one monotherapy we give. Aspirin, we load the patient with 300 mg dose, and we continue the aspirin 75 mg lifelong. Regarding the statin, we give atorvastatin 40 to 80 mg dose and rosuvastatin 20 to 40 mg dose rosuvastatin. Okay, we have to continue the aspirin and the statin for lifelong. Like if someone has the atrial fibrillation, like then we have to do this and had a stroke, then we prefer the warfarin. Okay, so giving the aspirin in a patient with the AF has no role. So if someone has a cardiac disease like valvular heart disease or non-valvular AF, then we have to give the warfarin, and you have to maintain the INR in between 2 to 3. So warfarin is the drug of choice in that scenario. There are research going on regarding the use of antidepressant. Okay, there are research going on. There are research also going on the neuroprotective agent like citacolin. Okay, edaravone. There are research going on. Okay, and definitely we need to counsel the patient regarding the disease course, and we have to also counsel regarding the significance of physiotherapy. Okay. The take-home message is that stroke is a condition where it has the abrupt onset of focal neurological deficit due to the focal vascular cause. It is of basically of two types, ischemic and hemorrhagic type. Ischemic is more common, and the common risk factors are advancing age, male gender, hypertension, type 2 diabetes mellitus, atrial fibrillations, and the screening question is they be fast, and we have to manage the stroke. Not only by giving the supportive care, but the definitive treatments like thrombolysis and thrombectomy should be done if the patient come within the time within the proper time frame to the hospital. Thank you so much for your kind attention. If you have any queries, you can write in a comment section.